Hey, hello and welcome to the first Yale Interventional Psychiatry Grand Rounds of this academic year. After a bit of a hiatus, we're thrilled to be back. This year, we have a fantastic lineup of presentations and an incredible group of speakers. We're especially excited to kick things off today with a record-breaking number of registrations. Thank you all for joining us. Before we begin, just a bit of a housekeeping. Activity director disclosures. Dr. Ostroff has nothing to disclose. I do work at another company in addition to my role at Yale, but I have no relevant conflicts of interest related to these educational talks. A mailing list. If you're changing email addresses, please send me a quick note so I can update the list. I get dozens of bounce backs with each invite, and I hate the thought of people missing out. Also, please feel free to forward these invitations to anyone who might be interested. These sessions are free to attend and open to participants worldwide. And I always welcome your ideas for future topics or speakers. Don't hesitate to reach out. Lastly, here's the CME code and instructions for today's talk. It's 53323. I'll also post the code in the chat a couple of times during the session. And with that out of the way, it's my pleasure to introduce my great colleague and friend, Dr. Samuel Wilkinson, whom many of you already know. Dr. Wilkinson is an associate professor in the Department of Psychiatry at the Yale School of Medicine and serves as the medical director of the Yale Depression Research Program. He earned his MD from Johns Hopkins University and completed both his residency and fellowship training here at Yale. Over the course of his career, Dr. Wilkinson has received numerous prestigious awards, including the American Foundation for Suicide Prevention's Young Investigator Award, the Brain and Behavior Research Foundation's Top 10 Leading Research Achievements, and the APA's Health Services Research Award for Early Career Scholars. Dr. Wilkinson has published over 100 peer-reviewed articles, and his work has been cited more than 6,000 times. And he is the principal investigator of multiple government and non-government funded projects, including the multi-center PCORI project, studying the very subject of the talk today. He's also on the editorial board of the Journal of Clinical Psychiatry. But in addition to his academic accomplishments, he's also a published author whose literary work has earned accolades such as the Best Indie Book Award, the annual National Indie Excellence Award, and the Literary Titan Award. Please join me in welcoming Dr. Wilkinson.
Thanks, Sina. I appreciate the overly generous introduction. You should tell my wife how great I am one of these days. So let me make sure. Am I sharing the right screen? Can you see?
We can see your full PowerPoint. Oh, now it's better.
Is that the right? Okay, great. So thanks for having me on today to speak. I'm going to mainly talk about this question here, whether there's a meaningful difference between ketamine and esketamine. Before I jump into this, I will display my disclosures. I get funding from a variety of sources. I will note that I do not have any personal conflicts with Janssen, which manufactures esketamine, but Yale does have an institutional conflict with Janssen because they own part of the patent for esketamine. That doesn't affect me except for the fact that I work at Yale. Just I just try to simplify this in a very brief agenda. I'm going to first talk a little bit about basics and background of ketamine and esketamine. I'll try to, I sometimes use them interchangeably, which is not a good habit to fall into for the topic of this talk. And so I'll try to be precise about my language. So first off, and then we'll dive into, whether there is a meaningful difference between ketamine and esketamine. So first off, I just want to go through a bit of a timeline as to kind of the story of first ketamine, because that was the molecule that kicked this off, and this is thanks to a great slide that Jerry Sanacora designed. So going back to the 1950s, a pharmaceutical company, I believe it was Park Davis, was trying to develop an anesthetic, and they developed this molecule that has since become known as phencyclidine. which is PCP or angel dust, has been used recreationally. And they quickly realized this was not a good anesthetic. It left patients, agitated and in an unmanageable behavioral state. And so they went back to the drawing board and they tried to tone down. One of the things that phencyclidine does is it has antagonism of the NMDA receptor. So they went back to the drawing board and they developed a molecule that had less NMDA receptor antagonism, less potent antagonism, and that was what became known as ketamine. It was synthesized in the 1960s, and its first clinical use was just a few years later. And one of the ways that culture influenced medicine in this regard was that what was going on in this around this time was the Vietnam War, and this led to ketamine becoming very popular because, unlike many anesthetic agents, it does not depress cardiac activity or blood pressure, and so it's generally safer than many anesthetics to administer outside of hospital settings where you can't necessarily have real-time monitoring of blood pressure and heart rate. So because of the Vietnam War, in part, ketamine becomes fairly popular fairly quickly. It was approved formally by the FDA in 1970 as an anesthetic. And again, as I mentioned, it became popular and made its way onto the list of essential medicines by the World Health Organization. A few years later, some neuroscientists working independently hypothesized that NMDA receptor antagonists might exhibit antidepressant actions. But as I think most of us on this here might know, it's not all positive. So ketamine had been noted to have some abuse properties, and in the late 90s was listed as a class 3 scheduled substance, which by definition suggests that there are some abusable properties of ketamine. So going back to the therapeutic kind of line, the first paper that really kicked off the excitement of ketamine as a potential antidepressant was published just the next year, and that was actually a very small cohort of patients that were treated at the VA near New Haven, near Yale. So it's most of the docs there are Yale faculty, and this was again one of the things that really kicked off the excitement. It wasn't until about 6 years later, however, that folks at NIMH first replicated this finding, and then things really got into gear in terms of the excitement and interest around ketamine as a rapid antidepressant. But again, as we know, it's not all just benefits. The World Health Organization, meanwhile, is kind of evaluating ketamine's risk versus benefits at various time points during the 2000 and 2010s. And then the especially during the 2010s, clinical use started accelerating. Clinical use, sorry, let me just contextualize. Clinical use for psychiatric disorders really started accelerating in the 2010s. And, the field of psychiatry was having this discussion of, how should this be used? Should it be used? Should it be used outside of research protocols or not? And the APA, the American Psychiatric Association, came out with a kind of, I think one of the first, if not the first that I'm aware of, really statements that were not necessarily guidelines because there wasn't enough evidence to justify guidelines, but, statement from key opinion leaders on the use of ketamine for depression. Now, all the while in the 2010s, Janssen, the pharmaceutical company, which is affiliated with Johnson & Johnson, has been developing not ketamine, but the enantiomer of ketamine, the generic of which is esketamine. The brand name is Spravato. And they gained FDA approval for esketamine for both treatment-resistant depression in 2019 and then depression with suicidal ideation in 2020. Now, just to complicate this picture a little bit, back in the simple days of the 2000s, early 2010, everyone thought that, oh, well, the mechanism of ketamine is clearly, ketamine's antidepressant effects are clearly the NMDA receptor antagonism. Well, there's been a number of reports that have cast some uncertainty onto that, that have suggested that, well, maybe it's, the AMPA actions of one of the metabolites of ketamine. Maybe you can have antidepressant effects that are independent of NMDA receptor activity. But nonetheless, esketamine was approved, and it got kind of a slow start for the first couple of years, but has since become more and more widely used, and I think is widely considered a commercial success. So just a little bit about the logistics before we kind of go into the meat of the topic of ketamine versus esketamine. So esketamine scheduling, based on the clinical trials that led to its approval, it's indicated for twice per week dosing for the first 4 weeks, and then weekly for a month, and then spread to maintenance. Now, maintenance, at least on the label, suggests it could be weekly or every other week, kind of indefinitely. I personally feel a little uncomfortable doing this weekly indefinitely, and I think many people, at least at Yale, feel comfortable if we can spread out to once every 3 or 4 weeks. The classic and most common side effects are just the dissociation that lasts probably a little less than an hour. Headache is common, nausea is common, and then a bad taste that sometimes happens when the medicine drips down the back of someone's throat. Esketamine is subject to what's called a REMS, or a drug safety program. Then some of the key highlights of this drug safety program are that treatments have to be done at clinic, not at home. You can't drive on treatment days. Patients have to enroll in a registry. There's a lot of paperwork for providers and the clinic, and they have to be kind of authorized as ketamine providers. So this is just, and one of the things that I'll highlight a little later is that ketamine has no such drug safety program. And this really represents not necessarily a difference in safety, but a loophole in the way that kind of medicine is regulated. So here's just a visual of kind of what I talked about in terms of the index course and the optimization maintenance course, et cetera. So a few recent kind of updates as to where ketamine and/or esketamine might fit in the algorithm for difficult to treat depression or treatment-resistant depression. I think 2 years ago, the results for what's called the ELECT-E study read out and were published. This was a study where patients referred for ECT were offered the choice to come into the study and be randomly assigned to receive ECT, like they referred, or ketamine. It was a large study, 400 patients, 5 sites. The majority of patients were outpatients. There was some evidence of what we might call differential dropout, indicating that there was a higher preference for ketamine. But overall, this was framed as what's called a non-inferiority study, meaning that the key question is ketamine as good as ECT for kind of moderate to severe treatment-resistant depression, most of outpatients? And the answer was that yes, it is up to a certain point. And in fact, we couldn't necessarily say this formally, but it looked like ketamine did a bit better in terms of efficacy in this particular sample, and it definitely did better in cognitive outcomes. Let me just show you what the data look like. So the top panels are the percent of patients achieving response based on either a self-report item, that's the top left, or a clinician administered assessment. And you see that at least nominally, ketamine has higher response rates. Now, again, because of some kind of formal statistical rules, we couldn't actually say it did better, but we can definitely say it's not worse than ECT. And on the bottom are the continuous outcomes, the average scores at various time points. of the patients who received ketamine and ECT. And as you see, the patients who got ketamine had lower scores for both the self-reported instrument on the left and the clinician administered one on the right, indicating better depression outcomes. Now, I will just contrast this a little bit with around the same time this study was going on, there was a European version of the study that was called the KET ECT, and this group that had a smaller sample kind of found the opposite. This is their figure, and looking at the MADRS, which is a very common clinician administered scale for depression. And what they show here is in the black squares, the patients that got ECT did better over time than the patients that got ketamine. So, you know, how do we contextualize these two kind of somewhat discrepant findings? Here's just a little bit of the breakdown, some sub-analyses, and you'll see that overall remission, you know, the patients that were assigned to ECT had a higher remission rate compared to the patients that were assigned to ketamine. When you look at by age, there's it's not necessarily statistically significant, but those under 50 tended to do a bit better with ketamine, 61 versus 50% of remission. The older patients, on the other hand, did much better with ECT, 77% remission versus 37%. And then psychotic depression, there were a small number of patients in them. They also seemed like they were definitely headed for significance there, almost 80% versus 50% remission. So, you know, how do we reconcile this? What do we take from these two different studies? Let me get to that. You know, one thing I think, you know, my takeaway from this is if you have a couple of key subgroups or you know, clinical or demographic profiles for inpatients, you know, if you're just looking at clinical efficacy, I would probably lean toward ECT. For older patients, you know, 65, 70 older, I would probably lean toward ECT. Psychotic depression, probably lean toward ECT. Strong history of substance use disorder or recent history or active even. This is not necessarily from the data from these two trials, but, you know, my clinical intuition suggests that I would probably lean toward ECT, but others I would probably lean toward ketamine. And one of the key reasons, at least first, that I would lean toward ketamine is a study that just came out today, which is a further, more in-depth analysis of this ELECT-D data that shows pretty clear cognitive differences in the treatments. These are various cognitive assessments, and their change in score from baseline to after the acute series, whether it's ECT or ketamine. And these little stars here suggest that across all of these domains, ketamine did better in the cognitive outcomes. And I think most clinicians would have assumed this is the case. Now, fortunately, again, most of these ECT cognitive issues tend to resolve fairly quickly after the acute course is over and patients are spread to maintenance. But at least during the treatment, I think generally, you know, ketamine is much more tolerated by patients. Let me jump to, I already went over this. Let me jump to another study. This is somewhat relevant, not comparing ketamine, but comparing esketamine to an atypical antipsychotic, quetiapine, for treatment-resistant depression. This was a study that was sponsored by Janssen, the manufacturer of esketamine, and it was, I think, if I'm not mistaken, exclusively conducted in Europe. They had to do this for basically for Europe to accept the drug and pay for it. It was a large study, 670 randomized, and the overall findings, the remission rates were kind of, you know, not super impressive compared to other studies, but there was definitely a difference in terms of esketamine versus the quetiapine group of 27% versus 17% remission at week 8, which is after the first 2 months of treatment. The continuous outcomes again, tended to favor esketamine, lower scores being better. So that's just a little bit of kind of background, some recent evidence of the ketamine esketamine story. All these studies, I think, are large, relatively well done, and fairly reliable. So let's turn to kind of the question of interest for today, and talk about ketamine versus esketamine. Is there any difference? And I usually definitely try to use generic names, but because ketamine and esketamine are so similar, I will probably lapse into using Spravato, just for clarity sometimes. So as my, kind of subtitle of the slide suggests, there's not a lot of great data, but there are lots of strong opinions. I think the strong opinions have kind of muddied the water and caused a lot of confusion among various, important stakeholders to this area. This is one website that we kind of scraped this quote from, of a prominent clinic's webpage. It said, to the treatment of depression, PTSD, etc., IV ketamine is the gold standard. As such, we do not offer Spravato at our center. So I would kind of disagree with that and say that there's some genuine uncertainty here. So first of all, what is the difference between ketamine and esketamine? Well, ketamine with kind of no prefix generally assumes that we're talking about the 50-50 mix of the S enantiomer and the right enantiomer. So going back to your, organic chemistry, some molecules are chiral. They'll have this point where there can be a kind of an enantiomer, a mirror image object, and ketamine is one of these. It has this chiral center here, and there's the left-handed enantiomer esketamine and the right-handed one R-ketamine. And the S enantiomer has about 4 times the binding potency at the NMDA receptor, and really, I think I think there's a little bit of confusion as to why esketamine was selected by Janssen to develop. And I think it has to do with this more than, say, issues of patent law and so forth. So I think they were trying to get as much concentrated therapeutic agent into a small volume to squirt up someone's nose. They didn't want to have a fire hose, obviously, and they chose. This was again back in the days when it was crystal clear that the mechanism was NMDA receptor antagonism. So they chose the molecule, the enantiomer, that had the higher binding potency at the NMDA receptor. Now, of course, also relevant to this question here is the R enantiomer effective for depression? And there has been some data studied this. So there are at least 2 studies of which I know. I don't think there are any more, but one is a very small academic study led by some folks in Brazil, and they kind of ran a very similar study to the very first ketamine study, but they used only R-ketamine. They had a single dose infusion. This was a crossover, and it didn't really show much. This was a very small study. I think there were 10 people, but that was bigger than the very first ketamine study that was done at the Yale VA. And this doesn't produce the same excitement that the original graphics in the 2000 ketamine study. This graphic that I just pointed up in black and white. That's the year 2000 ketamine study, showing a very clear separation in I think 7 or 8 patients, and then the one on the right is the study with R-ketamine, showing really not much of anything. So again, very small study. So you can't necessarily bet the farm on it, but there has been another, I think, relatively large trial sponsored by industry, a company called Perception. This was a phase 2A study of a little over 100 patients, double-blind, single IV treatment, 3 arms, placebo, 30, 60 milligrams of R-ketamine. And this study did not hit its primary outcomes. There was like a 1.5-ish difference between active and placebo arms. Of course, the caveat here was that the placebo rates were very high. But I think from these two studies, the emerging answer is are ketamine effective for depression? Probably not. Okay, so that of course is relevant in this question. Is there a difference between ketamine and esketamine? Because the main difference between them is that ketamine has the R enantiomer and esketamine does not. So looking at some additional data, one of the first studies I'm aware that tried to answer this question was a meta-analysis conducted by these folks, and Carlos Urratti being the senior author, who has led many of the pivotal ketamine studies from the NIMH. Their conclusion was that IV ketamine appeared to be more efficacious than intranasal esketamine. Now, there were some problems with this study, and one of the problems, this was pointed out, is that there was some misattribution. So some of these studies, they were put in the ketamine arm, but they're actually containing esketamine. And then this study, the Korea Mello 2019 study, it's the only study I know of published so far that is directly comparing ketamine to esketamine. So why they put this in the esketamine group and not the ketamine group, or why they just didn't exclude it, I don't quite understand. But probably the biggest problem with this and meta-analysis is that all these clinical trials are categorically different, and they're mainly different in terms of the ketamine ones are mostly small, single site, single dose. They're not FDA regulated, whereas the esketamine studies are multi-site, large, multi-dose, which is much more like it's given in the real world, and they were FDA regulated. So anyone who's run clinical trials knows that there's a world of difference between these two types of studies. Running a multi-site study, especially if you have something like 30 or 40 sites, is a very, very different beast than a small academic single site study. And you're, when you go to a multi-site larger trial, your effects are naturally going to be attenuated, whether you're studying, ketamine, whether you're studying Prozac. It's just, you don't have the concentrated expertise that these small single site studies done in academic centers have. So I'm not convinced by this, that IV ketamine is necessarily more efficacious than esketamine. I will note, as the top line notes, I kind of glossed over this. There's only one study I'm aware of that's compared esketamine directly to ketamine, and it used IV esketamine, right? This was not the Janssen product. This was IV esketamine. It was a single dose, and it really showed no meaningful difference between the two. It had reasonable power, statistical power. It had about, I think, 60 or 70 patients, but not a huge study, and it was single dose, and not using the intranasal esketamine, as is the most commonly used form of esketamine for depression. So there are some other studies. These are non-randomized clinical data, including from our own, that I'll go through briefly. So we have published our clinical outcomes in patients who are treated with in our clinic with either ketamine or esketamine. I think there's a couple of clinics that have published these clinical outcomes. I think we have the largest so far. So our sample is about 200, a little over 200, roughly, slightly imbalanced in terms of size, more patients in the ketamine arm than in the esketamine arm. They were fortunately, relatively well balanced in the things that we could measure. One of the things that I think is important is private versus public insurance. This is a marker of socioeconomic level. It's not a perfect one, definitely, but there were no statistically significant differences in a number of factors, clinical and demographic factors that we could measure. Okay, there very well could have been things that we couldn't measure, didn't measure well, and so forth. So what our data suggested, again, there's a lot of caveats here, so I don't want to overemphasize this, but things leaned a little bit in favor of ketamine. Okay, the variety of ways that we kind of slice the data. So So the caveat again here, this is non-randomized. There may have well been underlying measured differences between groups. This was not this was in a clinical setting rather than a research setting. And the acute course of ketamine was not the same during the period of observation. I consider this very preliminary, not definitive. One of the key weaknesses of all these studies, including this one that our group published, is that, by and large, if you have ketamine, if you receive ketamine in a clinical setting, your socioeconomic level is going to be higher than if you receive esketamine, because esketamine has fairly broad insurance coverage. Ketamine does not, and largely doesn't have, at our clinic, does not have public insurance coverage. So, socioeconomic status is reflective of health outcomes. And so, potential differences between groups could be solely attributable to differences in socioeconomic status. And we try, we measured public versus private insurance, which is a proxy, but it's kind of a crude proxy for socioeconomic status. Other studies have been published. This is a group from Toronto, led by Roger McIntyre. One of the problems with this study is that, this is a 2-site study, and those 2 sites, they exclusively treated either esketamine all at one site and ketamine all at the other site. And there's a lot of site variability. There's another study from Mayo, largely doing the same thing. This is kind of a meta-analysis that has looked at these studies, including ours, and suggests that at least in remission and response rates, although it may look like it's tending towards ketamine, there's nothing statistically significant. So what does this mean, practically, and especially in light of recent news events and so forth, I guess maybe not so recent. Some of you may have seen in the news that, Matthew Perry, his death was attributed in part, in large part, I would say, to ketamine. Is ketamine safe? What was that all about? And regulatory authorities, I think, are starting to crack down on what might be deemed inappropriate and irresponsible use of ketamine. This was a couple of years ago, really around the same time that Matthew Perry died, that the DEA stepped in and shut down a doctor who was prescribing ketamine, basically by mail, mailing it to thousands of patients throughout the United States. He had licenses in, I think, almost all U.S. states. So is it safe? How can we make it safe? If it's not, how can we, think about common sense guardrails on its use? One thing I'll also talk about is the maybe comparative. It's hard to do comparative, toxicity and cognitive effects, but this is an article that will be coming out next week, looking at the toxicity, the neurotoxic effects of ketamine and esketamine to some degree. We're not trying to compare them head to head, but just looking at what is known about toxicity. So, some people may not know this, but ketamine is neurotoxic. Okay, there's clear data from preclinical studies and human studies suggesting that, at certain doses, at certain patterns, frequencies, and so forth, this is not good for the brain. Now, where that threshold is between safe and unsafe is not exactly known. I would say that the long-term esketamine data is pretty reassuring. In most cognitive measures that were done in several years worth of data, so about 1,000 patients followed for several years, most cognitive assessments either got better or stayed the same. There was one in processing speed, especially in older patients, tended to get a little bit worse. We don't quite understand the clinical significance of that, but this is an issue. And you can read this paper; it'll come out next week. One thing I'll just highlight is that the FDA views these compounds differently. This is what the FDA has said. It says, though esketamine is derived from racemic ketamine, they're not the same. Animal studies have shown racemic ketamine can cause lesions in the brains of rodents. We don't understand the relevance of this finding in humans, but animal studies with esketamine do not show these brain lesions. Now, this is this is an interesting statement. I have some issue with that, and the studies that were done with esketamine in animals. There was some internal discussion by the FDA as to whether those achieve the relevant clinical levels when they were done in rodents. But it is interesting to note, the FDA does view these compounds differently in terms of their potential neurotoxic effects. So, some other parts, and I mentioned that there was there's a difference in the way these drugs are regulated. So esketamine, as you know, is generally intranasal. Ketamine is most commonly delivered intravenously. Esketamine has FDA approval. Ketamine does not. And because of that, esketamine is subject to this drug safety program called the REMS, and ketamine is not. And this reflects, again, not that ketamine is safer, but really a loophole in the way that medicine is regulated. And this has, I think, public health effects. Okay, so this is recent data from the Rocky Mountain Poison Data and Drug Safety Program. They have looked at abuse rates of ketamine and esketamine. And, ketamine, as you see, is creeping up over time. This is 2016 to 2023. Esketamine, this is essentially just noise. There's essentially no abuse of esketamine. Now, this study, it's hard to kind of study the phenomenon where someone is introduced to esketamine and then seeks illicit ketamine on the streets. The study can't necessarily address that, but the way that esketamine is packaged, the way that it's regulated, means that particular product, esketamine itself, is very, very difficult to abuse, and so you don't really see much in terms of abuse rates changing over time since it was introduced to the market. So, trying to kind of bring full circle, is there a meaningful difference between these drugs? Clinical efficacy, I'm still somewhat uncertain on this. Some of the observations lean in the direction of ketamine. I think there's reason that could just be confounding because, again, all else being equal, wealthier patients that get ketamine are more likely to be wealthy, wealthier at least, and so wealth and socioeconomic status are independent predictors of health outcomes. Cost effectiveness. So this is an interesting thing, factor. From what perspective? You always have to, if you're talking about cost effectiveness, you always have to ask a question: from what perspective, patient or societies? Now, no question, from the perspective of society, esketamine is more expensive because the drug itself is much costlier compared to the 50, 60-year-old racemic ketamine. But from the perspective of the patient, in most instances, esketamine is going to be more affordable because insurance companies, esketamine has generally wide insurance coverage. Okay, so that's just one kind of take on that. Is there a meaningful difference in safety? I would say yes, and this is purely because of the way that these are regulated. Cognitive outcomes depends on the dose. The esketamine studies, the long-term phase 3 studies, are pretty reassuring on cognitive outcomes. If ketamine is being used in the community in a way that's like really high or really frequent, I would worry about that with my patients. Abuse liability, I would say yes, there's a difference, again, because of the way that ketamine is regulated or is not regulated. Bladder issues, people who abuse ketamine recreationally, they really high doses, they can have really serious bladder issues to the point that they seek and or need reconstructive bladder surgery. To my knowledge, there's been no case report of that happening with esketamine. And again, the long-term data were pretty reassuring in terms of bladder issues. So I would say on these three items, esketamine is going to be safer purely because it has regulatory guardrails that ketamine does not. There's nothing about the intrinsic molecule, I think, that is necessarily that different, but it's the way that it's regulated. Dysphoric reaction. So if you've treated patients with ketamine or esketamine, you probably know that every once in a while you'll have a patient who has a really uncomfortable experience. Sometimes patients describe that they're dying or they are dead. It sometimes looks a little bit like a panic attack. In my experience, this happens kind of once in a blue moon. It's not common, but it's not uncommon. I'd peg the incidence at somewhere like between 1 in 100 to 1 in 200 treatments, although that's just an estimate. Is there a meaningful difference between the two with dysphoric reactions? I don't know. No one's ever really looked at that. Don't know. We are, conducting a study to this end to really try to provide more clarity on this issue of the comparative efficacy and safety and so forth of ketamine and esketamine. This is funded by what's called the PCORI, Patient-Centered Outcomes Research Institute, and we hope to enroll 400 head-to-head. Patients are randomized to one or the other. Patients can cross over for lack of efficacy or tolerability. We started this earlier this year, and we are well on our way to trying to provide some meaningful data to this question. So I'll end there and just say thank you to my colleagues in interventional psychiatry at Yale and also Yale Depression Research Program. So much of the work that I've been able to do and contribute to the field with has been in collaboration with so many of them, and they're I'm fortunate to work in their presence and alongside them. So I will stop here. Sina, I might be a little early, but maybe we could have some questions or discussion.
Yes, thank you, Dr. Wilkinson. I really appreciate it. Yes, we have a number of questions, and I'll go over some of the questions that were submitted, and then we'll open it up to the panel as well. Will the slides be available for reference once the lecture is over? I don't believe that the slides directly, but the recording will be available. So if you follow our website, you can email me or on LinkedIn, etc. You should be able to access the recording. There's another question, Dr. Wilkinson. There's increasing interest in using ketamine and esketamine to assist or augment psychotherapy. Do you think one would provide more benefit than the other? Whether either is synergistic is a separate subject.
Yeah, don't know. I mean, I think I've been interested in this question for a long time. Can you combine ketamine and or esketamine with psychotherapy? I've done a couple studies, mainly trying to look at it with CBT. I will note something about sometimes people use this term CAP or ketamine assisted psychotherapy. Sometimes what you see is people trying to do psychotherapy when patients are kind of acutely affected by ketamine, like in the hour or so after dosing. I don't, there's not really any data that is helpful. It to me, from like a neuroscience perspective, to me, it doesn't make a lot of sense because cognition is impaired during that time period. There's this kind of flip that happens. We don't know exactly when it happens, but it probably happens around, I would say, 3 to 6 hours after dosing, where you go from being somewhat impaired to being a little bit, your cognition is enhanced or definitely improved based on many patients with depression have cognitive deficits. So I would say the most ideal time to kind of pair them is not when people are kind of acutely affected by ketamine in the hour or so after dosing, but maybe later that day or the next day. There seems to be this window of plasticity. Animal models suggest that with a single dose, that window is open for about a week. With multiple doses, it's probably open for longer than that. But they're practical and they're scientific considerations, and the scientific considerations would suggest that doing it maybe the next day would be better than doing it while patients are in the kind of acute and impaired state effects of ketamine. Whether there's differential, cognitive, flexibility between ketamine or esketamine, that's unknown.
Thank you. And another question, is there any research speaking to how much of the rise in naturalistic ketamine use is attributable to folks using with therapeutic intent?
You're talking about recreational use, I think I'm going to assume that's what it means. How much is attributable to it? No, I mean, that's a really tough question to answer. I think most of us would think that a lot of this, yeah, it certainly has to do with the fact that it's more used clinically for mental illness. It's used in some kind of, wellness spas. Even if people aren't necessarily particularly depressed, they can find people who will give it to them as sort of a wellness retreat or something. That's definitely not something I recommend, I would probably recommend against that. But I'm sure this has something to do. How much of the increase in illicit use is due to people starting out with therapeutic, and then that's a very, very difficult question to answer. And I don't know, but I think it has something to do with it. How much, I don't know.
A couple more questions here. Any comments on IM and sublingual ketamine?
IM ketamine has pretty good bioavailability, close to say 90%. IV by definition is 100% bioavailability, but there really haven't been many, if there's not been a lot. I'm trying to think of one study that has used IM ketamine. I think there's been a report of clinical outcomes from a clinic that uses it. It's to me, it's a little unclear. Okay, what is the breakdown, the elimination, that sort of thing. How long should you safely keep patients in the clinic while they come back to a normal state? I don't know what you gain by doing IM ketamine other than a little bit of convenience that you don't have to get an IV that you wouldn't have from IV ketamine. Certainly, there's no data suggesting it's more effective. It's just much, much less studied than IV ketamine. The other one was subcutaneous. There's been, I think, 1 or 2 studies out of Australia that have looked at subcutaneous that may show some efficacy, but again, the most commonly studied form of racemic ketamine is IV, and around 0.5 milligram per kilogram over a 40-minute infusion period.
So I have a number of other questions. There more and more questions are coming in, but I just wanted to give the panel also a chance to see if there are any questions from the
They
panel.
want to dispute my answers or my presentation.
Sam, it was a great talk. I wonder if you can also comment about the other forms of ketamine, the sublingual, the lollipops. How would you dose IM?
Yeah, well, so I mean, a lot of these are in part to get away from having to come to clinic, and that's definitely something I don't recommend, except maybe under the strictest protocols. For instance, in a research protocol, there's just a lot of ways things can go wrong with at-home ketamine dosing. I think the studies that have purported to study this phenomenon so far have been generally weak and poor. There was a report that roughly 50% of patients who use at-home ketamine either report purposefully or unintentionally using it in a way that was not intended. So at this stage, I'm still mostly against this at-home use.
I'm assuming you include the racemic compounded nasal spray ketamine.
Well, for at home, yeah.
Thank you.
I can just answer a couple of these. There's a question about bipolar depression. So we published some of our clinical data on ketamine or esketamine with bipolar depression, and there's been 1 or 2 other clinics. I think Toronto did, and at least in our sample, we had about 45 or so patients. There wasn't any evidence of mania during the acute course. There were a few events later on, but these patients were followed for a long, long time, and it's not clear that the ketamine at all contributed to any of these cases. So is it reasonable to do? I think yes, in select cases. I would be most comfortable if someone's on a real mood stabilizer, lithium valproic acid, something like that, and they've exhausted other treatment options. No, I don't think it's something you want to jump to with bipolar depression. Bipolar depression is a tricky clinical thing. Not nearly as many treatment options. Often these patients are refractory. So that's my question about ketamine and bipolar depression. Back to you, Sina. What's
This is a interesting question. Thoughts on the 1973 paper, The Use of Ketamine in Psychiatry by Khorramzadeh and Lotfi, where IV racemic ketamine was administered. This is well before the 1990s or 2000s. And many of us wonder what would the field would look like if that paper was picked up more broadly. But I'll give you a chance to answer.
Jared, do you want to take this one?
Sure. It was a great early paper. It was actually looking at abreaction. Maybe somebody with psychoanalytic training can tell me what that is, but it was actually done well before. And the whole idea was that ketamine would facilitate abreaction, the release of catharsis. And interestingly, I think they treated 100 hospitalized patients, no specific diagnosis. They were just hospitalized was it Tehran? Where was it? Was in
Shiraz.
Iran.
It was Shiraz in Iran.
Shiraz.
Yeah.
In Iran, they just treated 100 hospitalized patients, and they actually had really good results. And interestingly, they played with the dose a little bit, and the dose that they actually came up with was 0.5 milligrams per kilogram. I'm not sure how it was being administered. It was never that clear in the paper, so I can't say it was given over 40 minutes. I don't know how it was administered, but it's really interesting. But it's like so much of science, things die on, they wither on the branch. People didn't pick it up. I could say with pretty good confidence that when my colleagues that did that first study back at the VA initiate that study, they were not even aware of this paper. So it really kind of withered on the branch until it was picked back up again. I'll leave it with that. Maybe somebody can tell me what that reaction is.
It's a return of a traumatic memory and an emotional expression. It might be what we would now call a K-hole. A lot of crying and shaking. I think it was probably during the Vietnam War they were using things like pentothal for the same purpose.
Another question, esketamine now approved as monotherapy seems odd for a medication that seems more appropriate as augmenting medication.
Yeah, I remember speaking with someone who led a lot of the trials for esketamine, including the monotherapy trials. I don't remember exactly what Janssen was trying to get with the monotherapy indication. I think it had something to do with European regulations. I honestly don't think they're getting a whole lot more commercial use of their product in the US because of that, and maybe a little bit more. But in terms of clinical, seems odd for medication. It seems more appropriate as an augmenting medication. Steve, I think most, at least myself, I don't want to speak for everyone at Yale, but I think a lot of us have thought of historically about ketamine as a part of the treatment, the overall treatment plan. So I think the vast majority of our patients still are on antidepressants. Every once in a while, we have that patient who's, can't tolerate any antidepressant, doesn't like the antidepressants. They've never worked for him or her anyway. And, this, I guess, gives us a little bit of flexibility, but it hasn't, I don't think, changed our practice drastically at Yale, the supplemental indication.
Sam, if I could just add, I think part of it was also that there were a lot of patients that had failed 6, 7, 8 different antidepressants in multiple classes, really had no response at all, that were looking to get treated. And without having data on the efficacy as monotherapy, the labeling was very clear. And then third-party payers, insurance companies were holding to that. So they were actually making somebody who has failed everything go back on something just so they could get the Spravato. And that was one of the reasons. But I definitely agree with you. It wasn't meant to say this should be, bumped up in the treatment algorithm or a first-line treatment.
Yeah.
There's also no requirement of how long you have to be on the antidepressant, right? You can be for an hour.
No, most
second one,
companies...
is there a time?
Oh, you're talking about before the monotherapy indication.
Right.
Yeah. Well, because the original studies, they started them concomitant.
Yeah, they were co-administered. Yeah.
You want to choose, Sam, which
Yeah,
ones? I
yeah,
don't
yeah.
know we can get to all of them. So
Maybe we could get to all of them. So Isaiah, you speak regarding dosing for question of efficacy. It seems that esketamine may be underdosed. So the esketamine doses, I think, approximate, I would say roughly 0.4 mg per kg and 0.6 mg per kg. Is that part of it? Can the differences in dosing account for efficacy differences as an important variable? At least with our study, I don't think so, because we don't go that much higher than 0.5. And especially in that first study that we published. Now, certainly, when you go up in dose, the fact that you can go up in dose more times with IV, you could go from 0.5 to 0.55 and then to 0.6. Every time you go up in dose, it's a diminishing returns, but there's a placebo effect, right? You're giving the patient a kind of a renewed sense of hope. Oh, we're going to try something new, an increased dose. So that might account for a little bit of that. I don't know anyone's really tried to untangle that. That's all I have to say about that one. Maybe a little bit.
Sam, before you move on
yeah.
to the next questions, I just wanted to repeat the code again for people who want to do the CME is 53323. So because we're getting to the end of the hour. So yeah, please go ahead with the other questions.
Okay. Has there been an exploration of potential differences in placebo or the non-specific effects between IV ketamine versus intranasal? Well, it doesn't even say ketamine, it's just IV versus intranasal delivery. I don't know. I mean, that's an analysis that could be done, I think, fairly easily. I don't think it's been done. We could do it.
There was actually just an interesting paper that came out, didn't look at that specifically, but looking at the placebo response, looking at, I think it was using esketamine, maybe some ketamine, but looking at it compared to psychedelics. And there was a big difference, much lower placebo response rates in psychedelic studies.
Yeah.
So,
probably because heightened and functional and blinding is my guess.
Exactly. But also, I think the really big thing for people to realize is that this esketamine studies, the placebo group got a brand new oral antidepressant. So it's apples and oranges when you start comparing these things.
Okay. Take on recent research pointing toward opioid-based mechanisms, ketamine's antidepressant effect. We have strong feelings at Yale about that. Well, I don't want to speak for everyone at Yale, obviously. I think I definitely don't think it's clear, right? I think if you impair your opioid system, you're going to have an impaired placebo response. So I don't think it's working as a classic mu opioid agonist is along the lines of heroin and so forth. Could it be partly responsible for the mechanism? Yes, but again, your placebo response is going to be impaired if you screw up your opioid system too much. Those studies were, well, the main study, I think a more recent one came out, right? But the one from 2018, 2019 was a pretty small sample. Okay. Neurotoxicity based on dose and frequency. How does esketamine compare to IV? Let's see. My understanding is that we require 10 to 12 treatments of esketamine at relatively higher doses versus IV ketamine, 6 treatments with fewer relapses than esketamine. I wouldn't say that there's data to show that IV ketamine has better relapse rates than esketamine. I also would, I would say that 84 and 56 milligrams of esketamine are similar to roughly 0.4 and 0.6 milligrams per kilogram of IV ketamine. So I would also push back on the assumption that you get relatively higher doses with esketamine. I think overall neurotoxicity is related to dose, frequency, and cumulative exposure. It's clear to me that doing this daily is not a good idea, and probably impairs the antidepressant effects that we're trying to induce, and may also contribute to neurotoxicity. Okay.
Okay, I think that was all. Again, thank you so much, Dr. Wilkinson. Thank you everyone for joining. As I said in the beginning, we have a number of very exciting talks coming up. So stay tuned, and we'll send the invites closer to the next one. Thank you, everyone.
Thanks, everyone.